I want to give you a number at the start of this video that I think most people have never heard, and that changes everything about how you should be thinking about your heart. Approximately 50% of people who die from their first heart attack had no prior diagnosis of heart disease, no angina, no hospital admission, no warning that their doctor had flagged. They were living their lives, working, raising families, exercising perhaps, and then they were not. The first symptom of coronary artery disease, in half of all fatal cases, is death. I am not saying this to frighten you. I am saying this because that statistic is, in my view, the most important argument for understanding cardiovascular disease before it announces itself. Heart disease is the #1 cause of death globally. It kills more people every year than all cancers combined, more than any infectious disease, more than any other single condition. And yet it remains the condition that most people feel least equipped to do anything about. They treat it as fate, as genetics, as something that either happens or it does not. After years of clinical practice, seeing the aftermath of heart attacks, reviewing the investigations that preceded them, sitting with families in the hours after an event, I want to tell you something clearly. The vast majority of heart attacks are not inevitable. They are the predictable endpoints of processes that begin decades earlier, that produce detectable signals years in advance, and that respond meaningfully to actions that are available to almost everyone watching this video. The problem is not that the tools do not exist. The problem is that most people do not know what to look for, what to test, or what to do. In this video, I am going to walk you through exactly how coronary artery disease develops over decades. The mechanism that most people have never had explained to them clearly. I will cover the risk factor constellation that multiplies your probability of an event. I will show you the warning signs that appear months to years before a heart attack, and the critical differences in how those signs present in men versus women. I will explain what happens during a heart attack at a biological level, so you understand why timing matters so absolutely. I will cover the investigations that can detect coronary artery disease a decade before a clinical event. And I will give you 10 evidence-based actions proven to reduce cardiovascular risk significantly. This is the most important video I have made for this channel. Let us get into it. Coronary artery disease does not appear suddenly. It develops over decades through a process called atherosclerosis, the progressive narrowing and hardening of the arteries that supply the heart with blood. Understanding this process is the foundation of understanding why prevention is so much more powerful than treatment, and why the warning signs I am going to describe in the next section appear long before an event occurs. The process begins with endothelial injury, damage to the delicate inner lining of the artery wall. This lining, called the endothelium, is only one cell thick and is extraordinarily sensitive to its environment. High blood pressure physically batters it with every heartbeat. Elevated LDL cholesterol deposits in the arterial wall. Cigarette smoke delivers oxidizing chemicals that directly damage endothelial cells. Chronically elevated blood glucose, as we discussed in the previous video on diabetes, glycates and stiffens the endothelium. Each of these insults causes microdamage, and microdamage triggers inflammation. Once the endothelium is damaged and inflamed, LDL cholesterol particles, particularly small, dense LDL, penetrate into the arterial wall and become oxidized. Immune cells called macrophages arrive to clear the oxidized LDL, but they cannot do so effectively. Instead, they become engorged with lipid and transform into foam cells, the characteristic cells of early atherosclerotic plaques. These foam cells accumulate, the inflammation intensifies, and a fatty streak forms within the arterial wall. This process can begin in the teenage years and early 20s. Autopsy studies of young soldiers killed in combat have found significant atherosclerotic changes in the coronary arteries of men in their early 20s. Over years and decades, the fatty streak becomes a mature atherosclerotic plaque, a structure with a lipid-rich core surrounded by a fibrous cap of smooth muscle cells and collagen. As the plaque grows, it narrows the artery lumen, reducing blood flow. When the narrowing exceeds approximately 70%, blood flow during exertion is restricted, and this is when angina symptoms first appear. But here is the critical clinical point. Most heart attacks are not caused by the largest, most obstructive plaques. They are caused by smaller, less obstructive plaques with thin, vulnerable fibrous caps that rupture suddenly. When a vulnerable plaque ruptures, its lipid core is exposed to circulating blood. This triggers immediate clot formation. The clot can rapidly occlude the coronary artery, cutting off blood supply to the heart muscle downstream. Heart muscle cells begin to die within minutes of losing their oxygen supply. The window for intervention, from symptom onset to successful reperfusion, is measured in hours. This is the biology behind the phrase, "time is muscle." Every minute of delay translates directly into more permanent heart muscle loss. And this is why understanding the warning signs, the signals that appear before the rupture, is not academic. It is life-saving. Cardiovascular risk does not work like a simple checklist where one factor causes one outcome. It works multiplicatively. Two risk factors together do not double your risk, they can quadruple it. Three risk factors together can increase it tenfold. Understanding the cluster of factors that interact to drive risk is therefore more important than focusing on any single element in isolation. The major modifiable risk factors are high blood pressure, which I covered in depth in video 2 of this series, elevated LDL cholesterol, smoking, type 2 diabetes and insulin resistance, covered in video 4, obesity, particularly visceral obesity, physical inactivity, chronic psychological stress, poor sleep, and excessive alcohol consumption. Each of these drives atherosclerosis through one or more of the mechanisms I just described: endothelial damage, inflammation, LDL oxidation, or plaque vulnerability. They do not operate independently. They amplify each other. The non-modifiable risk factors are age. Cardiovascular risk rises substantially after 45 in men and after 55 in women or after menopause. Male sex. Men develop atherosclerosis on average a decade earlier than women, though women catch up rapidly after menopause. And family history. A first-degree relative with coronary artery disease before age 55 in men or 65 in women is considered a significant independent risk factor. Genetic variants affecting LDL metabolism, inflammation, and clotting all contribute to familial cardiovascular risk. If you have a strong family history, the non-modifiable component of your risk makes the modifiable components even more important to address. Risk calculators, such as QRisk3 in the UK or the pooled cohort equations in the US, combine these factors into a percentage probability of having a heart attack or stroke within the next 10 years. These calculators are available online and are the tools your doctor should be using to guide treatment decisions. If you have never had your 10-year cardiovascular risk calculated, that is a conversation to have at your next appointment. It takes 2 minutes and changes the entire framework of the discussion that follows. This is the section of this video that I think has the most direct potential to save lives. Because the warning signs of coronary artery disease are there, they appear months to years before a major event, and the majority of people who experience them either dismiss them or attribute them to something else entirely. Let me walk through the most important ones. The most common warning sign of significant coronary artery disease is exertional angina, a tightness, pressure, heaviness, or squeezing sensation in the chest that comes on with physical effort and resolves with rest. The classic description is a feeling as though someone is sitting on the chest, but the clinical reality is that many people describe it as indigestion, as a tightening across the upper chest, or as a vague discomfort they cannot quite localize. It is often not painful in the dramatic sense, and because it comes on with exertion and goes away with rest, people adapt. They take the lift instead of the stairs. They slow their pace on walks, without ever connecting the pattern to their heart. Any new chest discomfort that appears consistently with exertion and resolves with rest is angina until proven otherwise. It must be investigated. Cardiac pain frequently radiates. It travels along nerve pathways to locations that have nothing to do with the heart anatomically. The most recognized radiation patterns are to the left arm, particularly the inner forearm and the fourth and fifth fingers, the jaw and lower teeth, the neck, and occasionally the upper back between the shoulder blades. Many people with jaw pain or a toothache that has no dental explanation are actually experiencing referred cardiac pain. Many people who visit their dentist multiple times for an unresolvable tooth problem are later found to have significant coronary artery disease. If you have unexplained jaw discomfort, left arm heaviness, or neck tightness, particularly if it occurs during exertion, This warrants urgent cardiac investigation. Progressive breathlessness on exertion is a sign that the heart is struggling to meet the oxygen demands of physical activity. As coronary artery disease advances and cardiac output falls, the body compensates initially and then begins to fail. People notice they are less tolerant of activities they managed easily before. The change is gradual enough that most people attribute it to aging or deconditioning rather than to the specific and measurable decline in cardiac function that may be driving it. If you have noticed a progressive reduction in your exercise tolerance over the past year or two, not sudden, not after an illness, but slowly and persistently worsening, this is worth investigating with a cardiologist. Palpitations, the sensation of the heart beating irregularly, too fast, or with unusual force, can be a normal response to caffeine, anxiety, or dehydration. But in the context of cardiovascular risk factors, palpitations warrant investigation. Coronary artery disease can produce areas of ischemic heart muscle that are electrically unstable and prone to arrhythmia. Atrial fibrillation, the most common sustained cardiac arrhythmia, is itself a significant cardiovascular risk factor that is frequently identified only when it causes an embolic stroke. Unexplained palpitations, particularly those that occur at rest, that are associated with lightheadedness or that last more than a few minutes, should be investigated with an ECG. Bilateral ankle swelling. Swelling in both ankles that is worse in the evening and improves overnight can be a sign of heart failure, a condition in which the heart's pumping function is insufficient to meet the body's demands. As the heart's output falls, fluid backs up in the venous circulation and leaks into tissue. The ankles and lower legs are affected first because of gravity. Many people attribute ankle swelling to sitting for long periods or to heat, and it often is. But in someone with cardiovascular risk factors, hypertension, diabetes, obesity, smoking history, ankle swelling that is new, progressive, or accompanied by any other sign on this list should trigger a cardiac assessment rather than a simple reassurance. This is the sign I want to spend the most time on, because it is the one most consistently dismissed, and it is the one most strongly associated with missed and delayed diagnosis in women. Women with significant coronary artery disease are far less likely than men to present with the classic crushing chest pain of a heart attack. Instead, the most common presentation in women is profound, unexplained fatigue, a tiredness that is quite unlike ordinary tiredness that may have been present for days or weeks before the event, and that is frequently attributed to stress, overwork, anemia, or depression. Breathlessness and nausea are also more common in women than chest pain. Study after study has demonstrated that women presenting with heart attacks are more likely to be sent home from emergency departments without cardiac investigation than men with identical symptom severity. If you are a woman with cardiovascular risk factors and you have been experiencing unexplained, severe fatigue, please push for a cardiac assessment. This is not hypochondria. This is pattern recognition based on clinical evidence. Dizziness that occurs on standing suddenly, orthostatic hypotension, is often benign, caused by dehydration or medication effects. But dizziness or lightheadedness that occurs during or immediately after exertion is more concerning. It can reflect a transient drop in cardiac output during increased demand or the hemodynamic effects of a significant arrhythmia. Pre-syncope, the sensation of almost fainting, during exercise is a red flag that requires urgent investigation. It should never be attributed to simply pushing too hard or not drinking enough water when it occurs during moderate activity in someone with cardiovascular risk factors. I want to walk you through the biology of a heart attack clearly, because understanding it explains everything about why timing matters so absolutely. A heart attack, a myocardial infarction, begins at the moment a vulnerable atherosclerotic plaque ruptures. The plaque's lipid core is exposed to the bloodstream. Platelets rush to the site and begin aggregating. The coagulation cascade activates. A thrombus, a blood clot, forms rapidly, and within minutes it can completely occlude the coronary artery. The heart muscle downstream of the blockage, the myocardium, is suddenly deprived of oxygen. Heart muscle cells begin to die within 20 minutes of losing their oxygen supply. The damage is irreversible from the moment a cell dies. Over the following hours, the zone of dying tissue expands outward from the area of complete ischemia into surrounding areas of partial ischemia, the penumbra, that can still be saved if blood flow is restored in time. This is the biological basis for the phrase, time is muscle. Every minute that passes between symptom onset and reperfusion, whether by clot-busting medication or by emergency angioplasty, represents more heart muscle lost, more cardiac function impaired, and a higher probability of death or permanent disability. If you or someone near you experiences sudden severe chest pain or pressure, particularly if it radiates to the jaw, arm, or back, combined with breathlessness, sweating, nausea, or a sense of impending doom, do not drive yourself to hospital. Do not wait to see if it passes. Call emergency services immediately. Chew 300 milligrams of aspirin if available and not contraindicated. The difference between calling immediately and waiting 30 minutes can be the difference between a full recovery and permanent heart failure. I cannot make this point strongly enough. For women specifically, remember that chest pain may be absent entirely. If a woman is experiencing sudden, severe, unexplained fatigue, breathlessness, nausea, jaw or neck discomfort, or a combination of these with any sense that something is seriously wrong, treat it as a cardiac emergency. The clinical evidence is unambiguous. Women who present without classic chest pain are more likely to be assessed as lower priority and to experience worse outcomes. Know this. Advocate for yourself or for the women you love. One of the most important things I want to convey in this video is that coronary artery disease does not have to be diagnosed reactively, after a heart attack or after angina becomes disabling. There are now investigations that can detect the disease a decade or more before a clinical event. These are not exotic or expensive tests available only to the wealthy. They are available through most healthcare systems or privately at a cost that is declining rapidly. Let me walk you through the most important ones. A standard lipid panel, total cholesterol, LDL, HDL, and triglycerides is the starting point. But I would push for a more complete assessment, apolipoprotein B, which is a better measure of atherogenic particle count than LDL alone. High-sensitivity CRP, a marker of vascular inflammation. Lipoprotein A, a genetically determined cardiovascular risk factor that is not addressed by standard cholesterol-lowering treatment and that affects approximately 1 in 5 people. And HbA1c, which we discussed in the diabetes video. These 5 tests together give a far more complete picture of cardiovascular risk than a standard cholesterol measurement. The coronary artery calcium score is, in my view, the single most underused cardiovascular risk assessment tool available. It is a low-dose CT scan that takes less than 10 minutes and measures the amount of calcium deposited in the walls of the coronary arteries, a direct measure of atherosclerotic burden. A calcium score of 0 carries an extremely low 10-year cardiovascular event risk, even in people with elevated cholesterol. A high calcium score reclassifies risk upward, often justifying more aggressive treatment than a risk calculator alone would suggest. In people aged 40 to 75 with intermediate cardiovascular risk, a calcium score can completely change the treatment conversation. A resting ECG detects existing arrhythmias, previous silent heart attacks, which are more common than most people realize, and conduction abnormalities. An exercise stress test assesses cardiac function under increasing demand and can detect flow-limiting coronary disease. A stress echocardiogram adds real-time imaging of the heart's wall motion to the exercise test, significantly increasing sensitivity. For higher-risk individuals or those with symptoms, a CT coronary angiogram, a non-invasive imaging test of the coronary arteries themselves, can visualize plaque directly and quantify the degree of narrowing. None of these tests are routine in most healthcare systems, but all of them are appropriate to request if you have significant risk factors and the resources to access them. These 10 actions represent the strongest and most consistently supported interventions for reducing cardiovascular risk. The evidence behind each of them is not preliminary or emerging. It is decades of randomized controlled trials, large cohort studies, and clinical observation. Together, they can reduce your 10-year cardiovascular event risk by 50% or more. Smoking is the single most powerful modifiable cardiovascular risk factor for the majority of people who smoke. It accelerates atherosclerosis, raises blood pressure, reduces HDL cholesterol, increases clotting tendency, and produces direct endothelial toxicity with every cigarette. But the remarkable fact, and the one I want to emphasize, is the speed of risk reduction after quitting. Within 1 year of quitting, cardiovascular risk falls by approximately 50%. Within 5 years, it approaches the risk level of someone who has never smoked. The cardiovascular benefit of quitting smoking is larger and faster than almost any medication available. If you smoke and you do nothing else on this list, quit. Nothing else comes close in terms of impact. For every 1 millimole per liter reduction in LDL cholesterol, cardiovascular event risk falls by approximately 22%, and this relationship is linear, meaning lower is better, particularly in high-risk individuals. Dietary reduction of saturated fat and trans fat is the first step. Replacing saturated fat with unsaturated fat from olive oil, nuts, and oily fish produces meaningful LDL reductions. For people with elevated LDL and established cardiovascular risk, statins remain the most evidence-supported pharmacological intervention in medicine, reducing cardiovascular events and mortality across all risk groups in which they have been trialed. PCSK9 inhibitors offer additional LDL reduction for people who cannot reach target on statins or who have statin intolerance. Know your LDL. Know your target. As I discussed in video 2 of this series, high blood pressure is the most prevalent cardiovascular risk factor globally and one of the most tractable. Every 10 millimeters mercury reduction in systolic blood pressure reduces the risk of major cardiovascular events by approximately 20%, stroke by 27%, and heart failure by 28%. The combination of lifestyle intervention, sodium reduction, DASH diet, aerobic exercise, alcohol reduction, and medication where indicated can achieve reductions of 20 to 30 millimeters of mercury in many individuals. If you have not had your blood pressure checked in the past year, please do so. And if it is above 130/80, do not wait. Regular aerobic exercise reduces cardiovascular mortality by 30 to 35%, an effect comparable to many pharmacological interventions. The mechanism is multiple. Exercise lowers blood pressure, raises HDL cholesterol, reduces visceral fat, improves insulin sensitivity, reduces inflammatory markers, and improves cardiac function and heart rate variability. The minimum effective dose is 150 minutes of moderate intensity aerobic activity per week, brisk walking, cycling, swimming. Adding 2 sessions of resistance training per week provides additional cardiovascular and metabolic benefit. The dose-response relationship continues above 150 minutes. More is better. But the biggest gain is from going from nothing to 150 minutes. Start there. The Preventive trial, one of the largest dietary intervention trials for cardiovascular outcomes, demonstrated that a Mediterranean diet supplemented with extra virgin olive oil or nuts reduced major cardiovascular events by approximately 30% compared with a low-fat control diet. The Mediterranean pattern emphasizes olive oil as the primary fat source. Abundant vegetables, fruits, legumes, whole grains, oily fish, and moderate wine with meals. It minimizes red meat, processed meat, refined carbohydrates, and ultra-processed food. This is not a weight loss diet specifically. It is a cardiovascular protection diet with a stronger evidence base than most medications in common use. Waist circumference is a better predictor of cardiovascular risk than body mass index because it reflects visceral adiposity directly. Target waist circumferences for cardiovascular risk reduction are below 94 centimeters in men and below 80 centimeters in women. Visceral fat reduction through calorie deficit, reduction of refined carbohydrates, increased physical activity, and improved sleep reduces inflammatory signaling, improves insulin sensitivity, and lowers blood pressure simultaneously. It is one of the few interventions that addresses multiple cardiovascular risk factors through a single mechanism. Short sleep duration, fewer than 6 hours, is associated with a 20% higher risk of cardiovascular events independent of other risk factors. The mechanisms include elevated cortisol, increased sympathetic nervous system activity, impaired glucose metabolism, and higher blood pressure in the overnight period when blood pressure normally falls. Obstructive sleep apnea, which affects an estimated 1 billion people worldwide and is severely underdiagnosed, produces repeated overnight episodes of hypoxia and sympathetic activation that directly accelerate atherosclerosis and increase the risk of atrial fibrillation, heart attack, and stroke. Treating sleep apnea with CPAP therapy reduces cardiovascular event risk measurably. If you snore heavily or have witnessed apneas, investigate this. Chronic psychological stress is now an established independent cardiovascular risk factor, not a soft lifestyle concern. Stress activates the sympathetic nervous system, raises cortisol and adrenaline chronically, increases platelet aggregation, promotes inflammation, raises blood pressure, and drives behaviors, smoking, poor diet, sedentary lifestyle, alcohol, that compound cardiovascular risk further. Structured stress reduction, mindfulness-based stress reduction, yoga, cognitive behavioral therapy, regular nature exposure, has demonstrated reductions in systolic blood pressure of 3 to 5 millimeters of mercury and improvements in cardiovascular biomarkers in multiple trials. The mechanism is physiologically real. Stress management is clinical medicine. The narrative around alcohol and heart health has shifted significantly in recent years. Earlier epidemiological data suggested a J-curve benefit from light drinking. More rigorous analyses using Mendelian randomization, which removes the confounding effects that plague observational alcohol studies, suggest that any cardiovascular benefit of moderate alcohol is at best minimal and at worst illusory, and that the risks of alcohol, including atrial fibrillation, hypertension, cardiomyopathy, and hemorrhagic stroke, are dose-dependent and begin below the thresholds previously considered safe. The current best evidence supports keeping alcohol below 14 units per week for women and men, with further reduction advisable for anyone with established cardiovascular risk. This is the action I most want to address directly, because medication avoidance, driven by concern about side effects, a desire to manage everything naturally, or simple inertia, costs lives in cardiovascular medicine more than almost anywhere else. Statins, when indicated by a 10-year cardiovascular risk above 7.5 to 10%, depending on guidelines, reduce cardiovascular mortality. Aspirin, in people with established cardiovascular disease, reduces recurrent events. ACE inhibitors and ARBs protect the heart and kidneys simultaneously. Blood pressure medications, as I discussed in video 2, prevent strokes and heart failure. These are not optional extras for people with significant risk. They are evidence-based tools that the clinical trials have demonstrated reduce death. Please have the conversation with your doctor about your risk score and whether any of these medications are appropriate for you. I want to leave you with the single most important thing I know about cardiovascular disease. It is largely preventable. The biological processes that lead to a heart attack take decades to develop. They respond to lifestyle intervention at every stage. The investigations to detect them early exist and are increasingly accessible. The medications to slow or reverse them are well established. What has been missing, for too many people, is the information to understand what is happening in their body and why it matters. Over the past 5 videos, we have covered liver disease, high blood pressure, kidney disease, type 2 diabetes, and now heart disease. These 5 conditions account for the vast majority of preventable death in adults over 40 worldwide. They share causes, they share risk factors, and they share solutions. I hope that watching this series has given you a framework for understanding your own health that your clinic visits alone have not provided. If this video helped you, share it with someone whose heart health you care about, a parent, a partner, a colleague. Subscribe so you do not miss video 6, where I will be covering the warning signs of stroke. The FAST acronym is not enough, and I am going to show you the signs that the standard public health messaging misses entirely. I will see you there.